I'm a pretty standard sized guy. I wear medium sized clothing, 160 pounds, and I have about 3 trillion cells that make me human. But that doesn't count the bacteria cells that are part of me. How many more cells should I add to that 3 trillion to give you my total number of cells? Any ideas? Are you understanding my question?
Double it.
Double it? 6 trillion. Any other thoughts?
Double that.
I'd say you're on the right path. We could go on, but I have about 100 trillion bacteria in and on me at this time. And I washed right before I came. So what we're talking about here is a lot of bacteria. And they are, some of them, going to fall into a category that we call as transients. Maybe we're out in the soil, maybe potting a plant, whatever, and we end up with a little bit of soil on our hands, and we decide to then go from that pot to another pot. We might carry bacteria with us on our hands to the next pot. That's a transient organism. It's not adapted to us. It doesn't grow on us, but we think of it as a hitchhiker going along for the ride till we get it someplace else. And in some ways, C. diff is that way. We can be carrying spores on our hands, and we can transport them to other places as well. Okay, so that's one category of organism. Another category is what we call normal flora. I'm going to talk more about them in a little bit. Third category is a kind of normal flora that actually benefits it as it exists within us. The normal flora are the very best adapted to us, and some of them, as I say, as they are there, actually provide nutrients for us in the way of vitamins that we don't have the ability to produce on our own. And they're very important in water retention. They help reabsorb all the fluids and electrolytes, and that becomes very significant in the course of this disease. And those are associated with over 500 different genus species organisms, microorganisms within our intestinal tract. That's a lot of different kinds of strains of cells that are out there. And many of them are all helping us reabsorb that water that's been used to make it easy to digest and then to absorb the nutrients that we've taken in the food supply. Well, those nutrients are also the ones that allow organisms to grow that we don't want at times. And so we end up not only with beneficial organisms that we have, but what I call potential pathogens. And definitely Clostridium difficile, or C. diff as you know it, is one of those types of organisms. It does serve as an opportunist, just waiting for its opportunity to strike when the conditions are right inside our bodies. When we talk about pathogens, they are pathogens because they can make us sick. They cause disease. And they are able to do that primarily because they produce toxins. And we're going to talk about a lot of toxins associated with C. diff if we have time. Those toxins are powerful, and they do have a tendency to have a lot of damage they create within the body. But they also have to be able to invade, and that means they have to be able to survive inside the body. They have to be able to get in, and they have to maybe find a way to keep the immune system from recognizing and getting too seriously concerned with them until they're ready to strike. So they have to invade, they have to produce some toxins. Those are my general characteristics of bacteria that I wanted you to have. Now let me talk in more specific terms about Clostridium difficile, or C. diff. C. diff is one of those organisms that is an anaerobic, spore-forming, rod-shaped bacteria. Are there any of those terms I need to go into? Anaerobic means no oxygen. It actually doesn't like to be in the air. It likes to be other places that are not having oxygen available. If the oxygen is available, they don't grow. Okay, so anaerobic, spore-forming spores. Everybody set with that? No problems. Okay. It is also an organism that is defined as a potential pathogen, as I said, and it is one that is able to grow in only one area of the abdominal cavity, and that is the descending colon or the rectal area, either one of those two spots. It's capable of adapting and living within those if conditions are right. Conditions are not right most of the time, however. Okay, so those are a couple of general things about the organism that you need to know. So why do we want to know about this disease? That's the next big question to tackle. We need to know about it actually because it is a disease on the rise in our country. CDC stats indicate that in looking over the last decade at microorganisms that are hospital-acquired organisms that cause disease, that almost all of those strains of bacteria are on the decline because of pretty good protective measures that are being instituted at hospitals, nursing homes, etc. But that isn't necessarily the picture for C. diff. During that same decade that those other organisms are on the decline, C. diff infections have tripled. That's a lot of growth in a 10-year period. Last year, 14,000 people died from C. diff. That's more people dying from this disease than there are people in our country that are females developing ovarian cancer. And of course, for every person that dies from this disease, there are close to 100 who survive it just fine. So imagine how many more cases we're talking about of C. diff than cases of ovarian cancer. Of course, there are a lot of other cancers out there, so I'm not trying to say cancer statistics are skewed one way and C. diff is really the one you've got to worry about. There's a lot more things to be concerned about with cancers. Okay, so that's another statistic that I think is important. We find these organisms affecting the older population, 65 and over. About half the cases are found there. The other half the cases are found in people less than 65. A huge portion of those are between 60 and 65 because our immune systems are not working so well at the age of 60s and 70s as they are working when we're younger and in our prime as healthy specimens. It is a disease that actually grows very quickly and can take off, but it almost always is taking off when antibiotics have been administered. Antibiotic administration is a key thing that leads to this kind of disease getting a chance to get its foot in the door, so to speak, within the abdominal tract. It is not well adapted as an organism to invade. It just sits there passively waiting for that chance to come in and take off. And almost all the cases can be attracted to the antibiotics. I told you that 50% of the people are over 65, but 90% of the deaths are over 65, which is just stating the case that I just made, that the individual that is older, the immune system doesn't respond and knock it out. And so it can be really serious for the individual as they get older. Now that's the second part of this reason why I wanted to emphasize. How many of you are over 65? It's a whole bunch of people, and so you're at risk. How many of you have taken antibiotics in the course of the last 3 months? Anybody been on antibiotics? Not too many hands? Okay, well, good. That means that that's not a high-risk area for you. Just the age is the biggest concern for you. How many of you have been on immunotherapy? I probably didn't say that right. Let me back off and say that again. How many of you have your immune system depressed because maybe you're going on a chemotherapy treatment regimen?
Doesn't look like any.
Nobody right now. That's good. So that's not then an issue for you. But there are four of these characteristics that we have that put you at risk, and one of them is the age. One of them that you have been on or just recently taken the antibiotics. A third being the fact that you are out there as an individual who's either been depressed in the immune system because of chemotherapy or because you're going to be receiving a kidney transplant, or you've received a kidney transplant or other transplant and they don't want your immune system to knock it out. Those are different things that compromise the immune system. Doris, I'm missing one of those. Can you remember what the other one is that I have on that list? 4 risk factors. Oh, you don't have a copy of the one? Okay, well, that's all right. There's a copy, I think, that Tom has that has the one I'm forgetting right at this moment on risk factors. There's a third big reason why you need to be concerned about this organism, another reason why you should be very worried about it. And that is because a new strain has arisen. That strain is one of those mutants that has come in and taken a stronger foothold in us. It is better able to invade. It produces more toxins that are the standard toxins, plus it produces a third toxin in addition. And as a consequence of this, it causes some very severe complications that we need to be very concerned about. So those, to me, are the 3 big reasons why we need to be concerned about this disease. It's on the rise. It's increasing. It's definitely one where this population is at risk, and it's one where there is a new strain out there, and if you weren't susceptible to it before because you were under 65 and didn't have any of those other conditions, then you now need to worry about it because the new strain doesn't target people under 65. It targets people that are young and healthy. It's capable of getting in and causing very serious disease once it gets into the body. And so I don't think any of us can say that we're not at risk today. We have to worry about this organism. So I want to then move quickly to tell you how it's spread. It's spread from person to person, but it always starts with fecal material. Feces are the source of the organism, and so it gets from the feces onto the person's hands. The person gets it on their hands, and they touch something, and they deposit the organism. And this organism then can convert itself into a spore, and it can sit on that spot that's been touched, like the podium up here. It can sit up there for months at a time. If nobody ever wipes this podium down, it's going to be fine and healthy. If pick that up, put our finger in our mouth, and allow it to get into our digestive system, the spore has a tendency to survive the digestive system. It gets through, it's deposited, and now it's waiting for its opportunity to strike. And in most cases, it tends to strike when antibiotics are available. Okay, so let me go through and give you the signs and symptoms of this disease next. If you are prone to get it, you need to know when to be worried about the signs and symptoms. So let me start by saying that it's a disease that is going to have moderate to severe diarrhea associated with it, and moderate to severe abdominal cramping. Those two are the primary early symptoms of the disease. There's also a concern with dehydration. That's another symptom that manifests itself, loss of fluids and electrolytes from the body, because when we have the diarrhea, we've got a watery discharge, and we're losing those fluids out to the stools. So dehydration can be a symptom. We try to correct for that, but nausea is a symptom, and that poses some issues in trying to keep the fluids in that we're adding to our body. And so dehydration is a concern. We also have to be concerned about blood or pus in the stool samples. That's another sign or symptom of the disease. With the nausea, there's a loss of appetite. There's also a tendency for weight loss. A lot of that weight being lost is the fluids being lost from the body. It's not that we're talking about something that goes on over months. It's something that goes on over a short period of time. So those are some of the major signs and symptoms of the disease. So when should you go see the doctor? I think that's a good question to be aware of, because everybody that's taken an antibiotic usually has an adverse effect to antibiotic, and you get a little diarrhea associated with that. That doesn't mean you've got to be concerned about C. diff taking off. Diarrhea is pretty common, and so we want to get down to the nitty-gritty of what are the reasons why we should go in and see the doctor when we have that diarrhea. They say that if your diarrhea is so severe that you're running to the toilet with the diarrhea 10 or more times a day for more than a day, that you should go see the doctor. They're saying that if you have blood or pus in your stool sample, you should go see the doctor. They're saying if you have severe abdominal cramping, you should go see the doctor. And they're saying that if you were taking antibiotics and these symptoms showed up, and I've left out one of the symptoms. One of the symptoms that's a concern is if you have a sudden increase in fever, then that's a sign you should go see the doctor. It's a risk. It is considered a risk factor that is very powerful. So you want to be going in to see the doctor if you have that fever show up during the course of that diarrhea. So those are a number of the reasons to go in and see the doctor. And the last one is if there are diarrhea continuing in the person for 3 or more days, 3 or more times per day, then you should go see the doctor. So that's the material I want you to have there. Then from there, I move on to another topic, and that one is, Doris, can you help me out? What?
What complications?
Yeah, the complications. Thank you. There are there are 2 kinds of complication for the most part, but a variety of different manifestations of complication. First of them is dehydration. We dehydrate, we lose the fluids from our body, and when dehydration is severe, we end up with lower blood pressures. As the pressures decline, the end result of that is a situation where the heart can actually stop beating. So we don't want that. That's very serious. Kidney failure is a second thing that happens, and it's more often to happen than the other getting to that extent. But each case is obviously one that's there for a reason, as a part of the reasons to be concerned. So the complication of kidney failure is very real because we need the fluids in order for the kidneys to function. And if those fluids are not being provided adequately, we actually add to the toxicity by having the urea concentrating, and it's toxic in and of itself, causing damage to the kidney. So those are the things that are on the side of dehydration. The others are all connected with the abdominal cramping. This disease, when it takes off, is going to produce these toxins within an area of the body that has been vacated by the normal flora. It's taken advantage of that antibiotic that you were on. It's knocked out the normal flora, and now the spore that was there and maybe been carried in months before gets the opportunity to sprout and grow. And it does do so, and it starts to produce the toxins. As the toxins build up, the end result is we have some of the epithelial cells that line that abdominal wall starting to die, creating little holes in our abdominal wall. And when those little walls are dissolved away to an extent that bacteria can slide through, and that doesn't take much of a hole, just one or two cells dying is enough to start opening a door. And if that toxin is strong enough to get to the other side of this wall, it's going to be possible to not only have ulcerative colitis as a complication, which is a description of the actual breakdown of the cells in the abdominal wall, but leaking out of the other flora in the digestive tract then starts to take place, and some of them get into the peritoneal cavity, and that causes peritonitis. That's another complication, peritonitis. That is very serious, and when that occurs, you have to go in and get emergency. You don't have to get emergency surgery, but you do need to get it surgically repaired to correct that kind of a problem. If the cramping becomes severe enough, the rectum actually goes into a strong contraction, and the end result of that is that the feces and fluids that haven't been reabsorbed are accumulating behind it, and it starts to cause the abdominal wall to expand like a balloon being blown up with air. And as that expansion takes place, if that's not immediately treated with emergency surgery, it can get to the point that the colon will actually explode. And that's very, very serious. That's called toxic megacolon as a third major sort of complication, all connected with the abdominal cramping. Now, you know that there are muscles to move the digestive system move food through the digestive system, and that food passing through is supposed to ultimately be allowed to be exited. But those muscles are the ones that cramp when we talk about the signs and symptoms. And those muscles, as they cramp, then are able to send all these complications into effect, not letting the toxins out, letting them build up, letting the organism grow and getting more concentrated. The whole colon can actually ultimately be inflamed as a result of all of the things that are happening with these toxins. And which strain is the one that's worst at all these toxins? The new strain. And that's why it's so much more serious than before, and why, in part, some of our precautions that we've taken haven't been adequate. So we want to look next, I think, at the ways that this disease is treated. And the way it's treated is with a couple of antibiotics. Now, typically, antibiotics have been a large contributing factor to the development of the disease to begin with. So you would think that's kind of ironic that we'd use an antibiotic, but that's about the only thing we can do to get this organism under control once it starts producing its toxins. So they use vancomycin as one of those, and they use an antibiotic called Flagyl, and I think that there are different kinds of Flagyl. I do not know this, but I think there are, and it's important that the Flagyl used has an active ingredient of metronidazole. I don't know if I said that right, nidazole. Metronidazole, and that is the important active ingredient that helps to kill this bacteria and thus rid it from the body. So those are a couple of easy ways to treat it. The most important thing that my wife wanted me to emphasize with you is the fact that this is a disease organism that really needs to be properly prevented. The best things we can do is to keep it from getting into our system. So that's what I want to spend my last little bit of time talking about, getting you to the point where you feel more comfortable with this process. And so let me start by saying, if you're in a hospital setting, you should, as a caregiver, be wearing gloves and gowns. And if you go to the site here in the squad where you come across a patient who's obviously having some real issues, maybe so weak that they're on the floor from the dehydration, and they are at the point where they have feces that they haven't been able to clean from their bodies even, because they are now so weak and so debilitated. And you come in on this setting and you're supposed to deal with it. You need to have you need to have gloves and gowns on too. And I know from what Doris told me, you don't have your gowns on typically when you walk in. You always have your gloves right there ready to put on when you get inside. But you want to have the gowns on if you encounter that really dirty setting. So take that precaution. That's a very important precaution for yourself. The gloves are good at protecting you, but it's also critical that when you get finished and you've discarded your gloves and the gowns in the biohazard bags, that you also wash your hands with soap and water. And that's the second thing I wanted to be sure that you understood, is that this is not the type of disease that can be controlled with the little alcohol rubs that are very prevalent today that people use. I know when we were on our cruises, they want you to spray your hands with this alcohol and wipe them off, and that'd be fine, but that wouldn't prevent the spores of this organism from surviving just fine, and we haven't decontaminated those spores. And so we need to be aware that alcohol is not an effective barrier in protecting us getting our hands washed. There's no substitute for careful soap and water washing of the hands. That's a very important thing. Now, what are we going to do to clean up the area afterwards? Disinfection is very important as well. Disinfection is one that is using, if you go by CDC standards and Mayo standards, 1 to 10 concentration of chlorine bleach. Just a standard household Clorox solution, or the generic equivalents of Clorox are fine. Any one of those is good. And what I would recommend as a protocol is the following. I would suggest that when you encounter any visible evidence of fecal matter on your material, obviously that sheet or whatever that's been contaminated, that's going to go in the biohazard bag, but that doesn't mean that everything is, quote, on the biohazard bag. If you see it, you want to just scrub that down with that bleach, 1 to 10 dilution of standard bleach. After you've scrubbed it down with a 1 to 10 dilution of the bleach, let it sit for 2 minutes. Then wipe off that solution. And then spray on, after you've wiped it off with a clean, dry rag, spray a weaker solution of chlorine bleach on it. And that's made up by putting a tablespoon of this bleach in a gallon of water and letting that sit in a spray bottle and spraying that over the surface lightly and letting it air dry. The water will dissipate, leaving the active ingredients of the bleach behind to protect that surface until that's used again. And that 2 minutes that you gave up front in the presence of the wet solution of the chlorine should have really been sufficient to knock out all the spores of this organism. But if they're going to get on there between now and the time that you use it again, the dried on bleach should help prevent it being able to really survive on there either. So it should be the best solution for you in terms of controlling this and keeping this spread down. So that's pretty much what I wanted to cover today. I did a lousy job of it in my mind, but that's all right. Now there's lots of time for you to give me some questions, and maybe I can go back and cover some of the pieces I forgot to mention.
Bill, I have a question for you.
Yep.
And we'll bring it more down to a squad level.
Uh-huh.
Right? I hear you say that mostly it's in the intestine and the rectal area and has to do with feces. All right? So a lot of times in the squad, we'll get the call and people just panic. Some go left and some go right. Some want to wear the gowns like all the time. Some want to wear the mask. I hear you say that it's not an airborne disease at all.
It is not going to cause any problem in terms of getting in your nose, in your mouth. I've told you it could pass through the digestive system, but most of the time when we're wearing those gowns, we aren't digesting anything. We're not swallowing anything. Our mouth's pretty much closed. It's coming through our noses, and it's not going to ever get a chance to get to the digestive system and down into the lower abdominal wall. So I would say there is no need for a mask.
Right. Now,
but gloves.
All right, gloves always.
Gloves always, and gowns are important if you see that you're going into a setting where there's probably been some diarrhea within this patient.
All right. On that case now, our dispatchers, usually when we do a lot of transports, we'll ask if there's any contamination or isolation problems. And let's just say there is C. diff. Well, we go to the hospital, pick up these people. So you walk in, you see the nurses walking around there. None of them are gowned. Yes, they'll have their gloves on. My assumption as an EMT was, if you do not see any fecal matter around, and those are, I'm going to use the word clean, because let's say they're kept somewhat clean in the hospital, and you do that transfer out, whether it's sheeting them out or whatever, if there's no active fecal matter present, you do not need to be gowned up. Am I being too blasé?
Have you the information up front that they were a C. diff patient, or did I miss that part?
No, up front they were a C. diff patient.
They were a C. diff patient?
Mm-hmm.
If they were called a C. diff patient, I would say that you should be wearing your gown too.
And that's while we're in the room, but now we're transporting these patients. Now down, we're walking down the corridor and in the elevator. Are we still all gowned right straight through to our ambulance and through the delivery of our patient? I mean, when do we take these gowns off and then dispose of them? Or, you know, I guess I'm looking for a little feedback on your opinion on this.
Okay, it's, yeah.
Judy, were you going to add
I just
something?
have a suggestion. When I go in and pick up a patient that I believe has got C. diff, I take a full sheet and I open it up and lay it on the gurney. Once I get that patient transferred with my gown on onto the gurney, I'll take and cocoon that patient in my full sheet and take my gown off and go out of the room.
I think
that's sufficient.
I think that is sufficient as long as you've got that sheet wrapped around the individual now.
Right.
Nothing has touched your gurney other than the sheet.
Correct.
So in that situation, we have nothing to fear. I think that makes good sense.
Now, on another question, we carry in our ambulance now 2 types of wipes. We carry a chlorine wipe, and we carry another sanitation type of wipe that we've been using for a lot of years. And the drivers sometimes used to have the spray in the ambulance. All right, and you talked about alcohol after, or excuse me, chlorine afterwards cleaning up. So now our gurney right now, we've dropped them off at one of the institutions, and we know that even though we've sheeted them properly, that now we've had a person with C. diff on our stretcher. Is there a good procedure for us now? Because we make another back-to-back run, and again, we want our next patient to be as safe as the first time we run in the morning. Is there another precaution or something we should take additional to make sure our stretcher is now clean?
Well, I was suggesting that if you see anything at all, I would always disinfect as if there's a potential for that spore to be there, even though we don't see any visible germs. We don't see these microorganisms ever, and we never see their spores, so we can't be 100% certain that the spore didn't pass through the sheet, for instance. So I would think we want to disinfect the entire surface with that disinfectant. I know you have to turn that ambulance around and run it right back out. 2 minutes, it's going to take you probably 2 minutes to get to the site, and it's definitely going to take you a little bit of time to get them loaded up. You're going to go in and assess. I think the 2 minutes will have elapsed, and you'll be able to wipe it down, and you can be confident you're not passing it down to the next patient that way. Does that make sense?
Yeah, yes it does.
Okay.
Any questions?
Sitting here for the past couple of minutes, I get the impression that the ambulance is a lot cleaner atmosphere than the wheelchair van. What do we do? The van.
I do not know what kind of. Do you have a gurney in the van? Do you have a wheelchair in the van?
Wheelchair.
And the patients in the wheelchair.
And the patients come into you with a wheelchair. Is that right?
We're bringing them to the hospital, yeah.
You're taking them wherever. You're either taking them back to their.
We pick them up from the hospital and bring them to rehab or home.
Mm-hmm.
What do? We wrap them in a sheet and put them in the wheelchair? Or,
I guess if they're C. diff patient, the wheelchair is going to go out with them.
Yeah.
You're going to have gloves on your hands when you pick up that wheelchair, right?
I don't want to get in a position where I was going to tell them, no, you keep them.
If I'm hearing you correctly,
Yeah.
you have your gloves on,
Yes.
and you're going to wheel this person back out.
Yeah.
If you're confident you're not going to touch your body with the wheels of the wheelchair, because you can bet for sure that patient has had her hands or his hands on those wheels of the wheelchair at some point in time, or on the arms of that wheelchair for certain. If you're confident you're not going to get that on your clothing, maybe you could get by without the apron on. But if I heard it was a C. diff patient, I would be inclined to say, if it's available to you on the van, to take and put an apron on and dispose of it like the other. I'd say an apron, gown.
I don't think we're ever told that as a van driver. I don't think we're ever told that a wheelchair patient has had C. diff. I've never been told A lot of times we're not told too much about what we're picking up to start with.
Life is full of surprises, though.
Yeah, I can't answer that question for you. That's your decision on that then, I think.
I understand that C. diff is a terrible bacteria, but how many cases or incidences have we had on the emergency squad that either our van people or our ambulance people have picked up C. diff? And also, we carry that's not an excuse or anything because it's out there, but we also carry disposable sheets that are plastic lined. If you can't wear a gown through the hospital, which they say you can't, you can use a disposable sheet that's plastic lined and try to wrap your patient in it. Same thing with the van. I would suggest that if you have any concerns or you know ahead of time to go and get those disposable sheets that are in the supply closet in the training building, not the training building, the ambulance squad.
At headquarters.
The what?
At headquarters.
At headquarters.
We carry a sheet in there.
Disposable? So, yeah, just protect yourself as best you can. We don't always know what people have. We're called into some situations and we have no clue whether they have C. diff or not. Sometimes maybe it's intentional that we're not even told. So you just have to protect yourself.
We definitely know that the disease wouldn't be out there because this organism is not one that is highly invasive. It's not like hepatitis. See, all you have to do is just walk in a room with hepatitis and you got a chance of getting hepatitis. It's very easy for a small sample size to create a major issue. That's not the case with C. diff. C. diff is one that has the spore that gives it the potential to survive for long times and isn't wiped out by some careless treatment processes, which is why I emphasize the treating steps I would go through, like other organisms. And so it's out there potentially, but it's not highly contagious as a disease. It's more contagious now that the new strain is out there, and that new strain has been out since 2000. So it's been around. It's get established in most every hospital.
Is that new strain called C. diff also?
It doesn't have another name. It's just one of those mutant forms that's gotten a little better adapted to set up the disease state, because it can push aside the normal flora. It can help that immune system. It can help provide detection by that immune system to an extent.
How long after you finish taking antibiotics are you at increased risk?
They say 2 months. 2 months after the last of the antibiotics.
Should we clean our stylus and our tough books after? I clean mine after every run, but if it's a possibility of C. diff, should I be cleaning it? I clean mine with alcohol. Should I be cleaning it with the Clorox? Because we're handing them the tough book, and then we're handing them the stylus to sign.
I know that alcohol has no effect on the spores, and if you don't know what you're up against, I would suggest wiping it down with a cloth that has the 1 to 10 dilution of the bleach. If you're trying to control C. diff, it isn't going to work. It doesn't have any impact.
And we talk about that tough book, and we bring it into the house and we'll set it on their counter, and we'll set it on their couch or on the edge of their bed while we're doing this or that.
And those spores could be any one of those places.
So, yes, a very good idea that they get really clean during that process.
I even write it down when I first get there.
Blood pressure machines, another.
Yeah, stethoscopes, the blood pressure cuffs, they all need to be treated in a like manner. And the treatment in every instance, because we are worried about C. diff, is the treatment with Clorox.
The question I have is actually for someone from the emergency squad. the wipe downs that we use on the blood pressure machine, is that alcohol? So basically that's effective.
That's Cavicide. I'm not sure that's alcohol.
It's not alcohol.
It's an antibacterial.
Yeah, is Cavicide the one you brought home for me, Doris?
The information, yeah.
It is called
Okay,
Cavicide.
let me tell you what I if you have one of those right there with you, I glanced at that when my wife brought a sample home because I wanted to be sure I had that background. I wanted to know what you were using. I did not see any type of spore-forming organism on the list that it was effective against. But if you read that, I'll tell you if any of those are spore formers.
I contacted the people that make the Cavicide directly off with that question. Cavicide is not effective against C. diff.
Well, you have got the answer for us then. That's good. I wouldn't think it would be because it would be listed. And I just didn't want to make sure I didn't miss a spore former.
You mentioned the antibiotics that are the ones that cause the most problem.
What was that? Which? Oh, my wife wanted me to mention something else. She didn't raise a question for everybody to hear, but I'll repeat it. She wanted to be sure that you knew that broad spectrum antibiotics are the ones that are the serious ones to be concerned with this disease. Broad spectrum ones knock out a whole lot of flora. Now let me back off and go to one of my favorite scenarios. If I were to be critical of doctors, I would say that one of my criticisms would be that they go through shotgun approach to disease at times. They don't know what the disease is. You're coming in with some symptoms. Maybe there's a little diarrhea. That might be a sign that there's something out there that needs to be dealt with. Maybe it's a broad spectrum antibiotic that I'll give. And maybe it's a virus and it'll have no impact whatsoever, but nevertheless, they want to use this broad spectrum antibiotic because it'll get all kinds of things without us having to culture and figuring out what it was. And maybe we'll be lucky and it'll knock it out because it works against a lot of organisms. Well, the broad spectrum antibiotics are penicillins, cephalosporin, clindamycin, and a fluoroquinolone, which is the type of organism. I know that antibiotic better as Cipro. I take that as a protective every time I go in to see my dentist because I got a strep infection that led to my loss of my vision ultimately. I had a bad valve and it set up my sight problems ultimately. So they want to be sure I don't have my other valve having to be replaced.
How about any other questions? Back in the corner.
We are carrying two different types of antibacterial wipes on these ambulances. One is the Cavicide, which is a red-topped one, which Judy is holding in her hands right now. The other one is actually a Santa Claus with bleach, and it has an orange top, and it specifically states on the label that it is good against C. diff. The reason that we started to take that and use that was because the hospital was using it. So we piggybacked on their information and said, if they're using it, it must be, and it's good for them, it's got to be good for us. Until we found out that if you try to use the Santa Claus with bleach without putting gloves on your hands, and you happen to they're kind of wet, and it splashes against your navy blue pants, they're not navy blue anymore.
They're
spotted.
a little bit spotted after that. Polka dot.
They become polka dot, is right. The other thing that we found was that they are not good for leather. In fact, they cause the leather to crack, which are the pads on our gurneys are a leather composite, and we have to worry about that. They're not too good on the straps either because the bleach gets in and starts to corrode the fabric of the straps, even though they are, again, a composite of different types of material. Bleach can do a number on anything. However, what we have said is if you are handling or you have somebody who has C. diff, use the bleach wipes to wipe down the ambulances. Make sure you have your gloves on. Put on the gown to protect your clothing, and wipe everything down, and do a double wipe from what I'm hearing you say, Doctor. Double wipe, use a double wipe. Wipe it down, let it air dry, and wipe it down one more time, using the Santa cloth with bleach.
And
They are in the ambulance in cabinet number 3, if I'm not mistaken. If they're not in 3, they're in 9. It's one of the 2 spots. But you will find them because they've got orange tops on them. They look like this, except that the top is orange.
Any other questions? Now's a good time to ask them over here.
Just a word of caution, we talked about the tough books, and that the bleach may not be real good on the tough books because it's a very corrosive chemical. And metal, any kind of metals, the gurneys, a loading system, we ran into questions about that when we were doing the bleaching in the ambulance, that we don't want to be overloading the ambulance with the bleach.
Yes, that's correct. Thank you, Barry, for bringing that up. And when you're using, if you do use it on the tough books, you've got to be very careful with the glass, and you've got to make sure that it doesn't get anywhere near the battery, which is underneath the tough books. You have to be extremely careful that you don't even get so much as a drop of that into the batteries, because let me tell you, it will corrode the hell out of the batteries, and the tough books will be gone in a very short period of time.
that's very true. I guess my question to you, not having any familiarity with these wipes, are they moist enough that they actually drip?
Yes. Yes, they are.
Okay. So they are pretty damp, and you need to take the strong precautions you're urging them to do. And remember what I said, you don't have to leave it on there forever. 2 minutes will kill just about everything.
One other thing, Doctor, use them in a well-ventilated area. So, in other words, if you use them on the ambulance for the gurney, make sure you have the gurney out of the ambulance. You air dry it before you put them back into the ambulance. If you use them on any of the equipment in the ambulance, make sure you take it outside and allow it to dry in the air before you put it back in, because the fumes linger for a very long time on the equipment.
Can I add something?
Sure.
When he was talking, he said, 2 minutes, wipe it off, spray it with the weak bleach. The weak bleach is not going to do the kind of damage you're talking about on the gurney or anything. So a quick wipe, 2 minutes later, wipe it off and just spray it with a weak bleach, which we aren't carrying presently.
We're not carrying that
But the
presently.
weak bleach would then be the thing to let air dry.
Every incident that we go on, or just on those suspected of?
Just those suspected of C. diff.
Because that red top combats a lot of things.
That's correct, it does. That's why we use the clavicide. That's clavicide. The orange top is the Santa Claus with bleach.
So the drivers still use the spray to spray down the gurney if there's no suspect of C. diff.
Right. That's called, that's the clavicide. That's what we've been using for years. And it's
hoping so.
effective against most everything except C. diff. C. diff, and there's a couple of forms of TB that it's not effective against, but it will kill just about everything else.
Yeah, I read it. It's very conclusive.
If you have any more questions out there, now's the time. Again, now's the time to ask them. Nothing from nobody?
Good.
Thank you.
Thank you, guys.
Thank you.